learn a bit about you as well as obtain feedback for future seminars. It's with great honor that I introduce our speaker, Dr. Farai Mavhunga. Dr. Mavhunga is the unit head for vulnerable populations, communities, and comorbidities at the World Health Organization's Global Tuberculosis Program based in Geneva. He's a medical doctor with specialization in HIV/AIDS and public health. He has contributed to several journal publications on TB and HIV-related topics and has experience in clinical and programmatic management of TB in high-burden settings. Dr. Mavhunga has previously served as a National Tuberculosis Program Manager for Namibia for 10 years. Dr. Mavhunga, I now turn the program over to you.
Okay, thank you so much, Rajita. Good morning, good afternoon, good evening, everyone, and welcome. Thank you for joining this talk. Let me just share my screen. Okay, if you can confirm if you can see my screen and that is in full screen.
Yeah, I think we have your, I don't know if you have two screens. We have your screen with your speaker's notes on it. So I don't know if you have a second screen that has the slide in full screen mode.
Okay, let me try that again.
Sure.
How about now?
Perfect, that's great.
Okay. All right. So once again, thank you so much for having me to give this talk. As introduced, I work for the WHO Global Tuberculosis Program. So you will have noticed that at the time that I submitted my bio, the name of our unit was actually called Vulnerable Populations, Communities, and Comorbidities, VCC. We have since updated the name of the unit, I think to be more reflective of the work that we do. So the unit is now called People-Centered Services, Communities, and Determinants. So those are the aspects that we address when it comes to the global tuberculosis response. So it's within this context that I think you've invited me, and thanks again to give this talk. So I have quite a bit of a background as highlighted in TB programming, but also in clinical care. But I think for this topic, we'll be touching mainly on the non-medical aspects of TB control. So the outline of my talk, I'll briefly give an overview of the global burden of TB and just reflect a bit on the impact of COVID-19 on TB, and maybe just use HIV as a reference to see, the differences in impact that COVID had on the, on the epidemics. And then I will briefly also touch on the progress towards key end TB targets. And then we'll go specifically more to health-related risk factors. So the way I propose to cover it is to look at determinants in two broad categories. The so-called health-related risk factors in one category where we have probably advanced a bit more. And the other broad category would be the socioeconomic determinants. I'll then end by looking at what we are doing for each of those, at least from a WHO perspective, to try and address those determinants. So that will be the outline of my talk. Most of the data that I'll be talking to is published in the WHO Global Tuberculosis Report 2023, which is available online and also as an app that can be downloaded, and you can play around with it to get data at different levels, region, countries, ETs, or specific indicators. But suffice to say that in terms of incidence of TB, about 10.6 million people fell ill with TB compared to the previous year. So the data are for 2022. So compared to 2021, where it was around 10.3 million, and in 2020, which was around 10 million. So this is an upward trajectory, as you can see on the figure on the left. I don't know whether it's a good news or not, but at least the drug-resistant TB burden does not appear to have increased significantly over these past few years. It has relatively remained stable. Fortunately, we have started to see a decline in mortality from about 1.6 million in 2021 to around 1.3 million in 2022. This kind of reverses the trend that we've been seeing since the beginning of the COVID-19 pandemic. So if you can look at the figure on the bottom left, you see that the total number of deaths have been consistently going down until around 2019, where we had that increase as a result of COVID-19. So that trend seems to have changed now. We now see the continuation of the declining trend. However, we unfortunately did experience quite a number of excess deaths as a result of the COVID-19 pandemic, and I'll touch on that. And then in terms of the global burden of TB, as many of you would probably know, it's not uniformly distributed across the world. There are countries that contribute to the more significantly than others to the global burden. So for example, 8 countries in 2022 were responsible for about 68% of the global cases. And we do have the list, which I assume many of you would be familiar with, of high TB burden countries, and 87% of the burden is from those high TB burden countries. Coming back to the impact of COVID, and I think this is important as it is, it is shaping our programming going forward and is affecting our trajectory towards the achievement of the end TB strategy targets. So COVID-19 between 2019 and 2022 resulted in about 500,000 excess deaths due to TB. And you can see that on the graph on the top left-hand side of your screen. And TB in 2022 remained the second leading cause of death from an infectious agent after COVID-19. And we can see on the figure on the bottom left that while the TB deaths increased during the COVID-19 pandemic, HIV AIDS deaths, they continued on a downward trajectory. So there does not seem to have been a significant impact on TB deaths, on HIV deaths as a result of the COVID-19 pandemic. And we probably think that this is largely because a lot of the HIV services are available outside health facilities. And so they continued to access these services, unlike a lot of our TB services, which rely on the health system for them to be available. And again, deaths from TB in 2022 were almost double those due to HIV/AIDS. Since we're talking about the determinants of TB, I think one of the major determinants that we repeatedly are aware of in the global TB report and in many other reports, including in TB prevalence surveys, is that TB significantly affects men more than women. And the highest burden is in adult men, who accounted for about 55% of all TB episodes in 2022. And similarly, gaps in detection and reporting are higher amongst men than women. And this comes back to our unit's work on addressing some of these biological determinants that we have to have responsive programming that responds to some of these dynamics. So the global strategy that is guiding us in our response to TB is the End TB strategy. And already within the End TB strategy, it looks at both the medical as well as the determinants. So if you look at pillar 2 of the End TB strategy, so pillar 1 is mainly around the medical interventions, but also which includes addressing the medical or the health-related risk factors and determinants. So we have specific activities to address HIV comorbidities and TB-associated impairments and disabilities. So already within the strategy, those aspects are reflected. Similarly, in pillar 2 of the End TB strategy, we also have interventions to address some of the socioeconomic determinants of TB through social protection, poverty alleviation, and action on other determinants of TB. And these interventions were factored into the model that is presented in the chart on the top left-hand side of the screen, which shows what we could do with current tools. So the trajectory, how we could impact the decline in TB incidence globally. Firstly, through optimizing current use of the existing tools, but also within that context, pursuing universal health coverage and social protection. So through this, we were already projecting that this would significantly affect the trajectory of the global TB epidemic. That would contribute to reducing it from about 1.5% per year, that is the decline, to around 10% per year by 2025. So we are approaching 2025. Where are we? Unfortunately, we are still very far away from the target. And part of the reasons that where we are now, apart from the COVID-19 pandemic, is that we have not optimized some of the interventions, and social protection is probably one of those interventions. So I've already touched on this, that at least we've started to reverse the trend in mortality that we had seen over the past few years due to COVID-19. But compared to where we want to be, so the 2025 milestone target is to reduce TB mortality by 75% compared to 2015. As of 2021, 2022, we were only at 19% net reduction, unfortunately. So quite far from the target. Similarly, the target would have been to reduce the incidence from 146 per 100,000 to 130 to around 50 per 100,000 by 2025. But unfortunately, we are still significantly, it's much, much higher than that at around 133, which is only an 8% decline compared to the 50% decline that we were targeting in the End TB strategy. So coming back to the topic that I am focusing on today, and this really talks to an area that I think many of you would be aware of, many of you would probably be convinced about, but probably many of you would agree that action is not as much as it should be. And I think there are very good reasons for that. So touching on some of the major risk factors. So there are various aspects, both health related, like the ones in red, but also the socioeconomic aspects, the ones in black, that put people at risk of TB. And addressing these, and one of the arguments that is frequently brought up is that this is beyond the scope of TB programming. So for many of these, while that could be true, I think starting with the people with TB in front of us, addressing these needs comprehensively would go a long way to addressing the background incidence of TB. And I'll come back to this discussion a bit further down. Now, more specifically related to the health-related risk factors, and I think we have done a bit more work on these, but from the WHO side, we are also working quite hard to make sure that there's updated guidance on how to address these determinants. One of the main ones, as you probably know, that there is a direct relationship between undernutrition and the incidence of TB. So you see that on the chart on the right. So as undernutrition increases, similarly, the prevalence or the incidence of TB also increases. And if you look at on the left, GDP, a marker of income or poverty, inversely, as the GDP increases, you also have a decline in TB incidence. Each of these dots represents a country in these plots. So again, I think, in the discussion on TB vaccine development and TB prevention, I think we do have some of what we know, some of these effective interventions can work for TB prevention. In the Global Tuberculosis Report, we routinely report on the contribution of specified health-related risk factors. And these are the 5 that contribute or that are responsible for about almost half, probably around 45% of the global TB burden. The most significant of them is undernutrition. As you can see, it increases the risk of TB by 3 times and is responsible for more than 2 million of the episodes of TB annually. And similarly, we also have smoking, alcohol use disorders, HIV, and diabetes also being significant contributors to the global TB epidemic. So these are comorbidities that we can actively address, both as a way of preventing TB, but also as a part of comprehensive care for people with TB. So I'll not go into the details of the references of the studies that that contribute to these findings. So you will have, I think, these slides in case you want to look at some of these specific studies. So this is the same information, basically just showing out, the relative contribution of undernutrition to the global TB epidemic with HIV infection, alcohol use disorders, smoking, and diabetes. And I have a few more slides which basically re-emphasize the role of these comorbidities. So for most of them, not only do they increase the risk of TB, but they also increase the risk of poor outcomes for those who are on TB treatment. So as we've highlighted earlier, as undernourishment increases in the population, the TB incidence also tends to increase. There is a direct relationship. But in addition to that, also, undernourishment is also associated with unfavorable outcomes of the TB treatment. And this can be highlighted from this study that is summarized in the table on the right of your screen. So this applies to both BMI, either BMI being low at the beginning of treatment, unchanged BMI during treatment, or decreasing BMI, or severe studies. So all those were associated with poorer outcomes for those on treatment for tuberculosis. I would imagine many of you are familiar with the role of HIV in the global TB epidemic, but suffice to say that the bulk of the TB HIV burden is in Africa, with 27% of HIV deaths in 2022 being due to TB. And around 10%, more than 10% rather, of people living with HIV die during TB treatment compared to 4% of all TB patients. So again, highlighting the fact that even those who are on treatment, people living with HIV have poorer outcomes compared to those with compared to all TB patients, that is those combined with and those without HIV. Similarly, smoking or exposure to smoking. So in addition to active smoking, also secondhand smoke exposure is also a risk factor for tuberculosis. So again, this study by Patra et al. From 2015 highlights that that risk, that it's not only active smoking that is associated with the increased incidence of TB, but also exposure to secondhand smoking. And then a few other studies also demonstrate the association. Hi, can you hear me?
Yes, go ahead.
Okay, thanks. All right. It also demonstrates that these few other studies, they do show that unfavorable outcomes are also associated with exposure to secondhand smoking. So again, it reiterates that all these determinants, they have a dual sort of a double effect on TB. On the one hand, increasing the burden of TB, but on the other, also increasing the risk of poor outcomes. And the same applies to alcohol use disorders. If you can see on the chart on the left, the prevalence of alcohol disorders in people with TB, about 30%, according to this study by Nature et al. Again, when we go to treatment outcomes, we also realize that for both drug-resistant and drug-susceptible TB, unfavorable outcomes were higher. The risk of unfavorable outcomes is higher across the board in people with alcohol use disorders. And then I think the last comorbidities, I'll also briefly just touch on mental health. But the last of the sort of risk factors that we report in the Global Tuberculosis Report is diabetes. And as you know, I think we have increasing incidence of diabetes globally, which also has potential implications for the global TB epidemic and its dynamics in terms of distribution in the populations where diabetes is high. And so there's firstly the increased risk of TB, but also the increased risk of MDR TB and the increased risk of adverse outcomes. So again, I think similar to all the other risk factors that we have touched on, diabetes also has that dual effect when it comes to TB. One important comorbidity, although we do not report on this separately in the Global Tuberculosis Report, is mental health disorders. This is one of the commonest comorbidities in people with TB, with one meta-analysis putting the prevalence of depression in people with TB at around 45%. And also, there is an increased risk, according to this study, of TB incidence in people with depression up to 2.6 times. And also with schizophrenia. So mental health disorders, again, while we don't routinely report on them as a health-related risk factor, it's one of the commonest comorbidities in people with TB. And in addressing the determinants, of course, a lot of these, they do overlap. I think addressing mental health related issues should be a key component of it. Now, what are we doing in the WHO Global Tuberculosis Program to try and respond to all these needs, specifically on the health-related risk factors? So in WHO, we have several, or we've had several different guidelines to address different comorbidities. So you see there was a monograph on TB and tobacco, a collaborative framework on TB, nutritional support, etc. So we have a number of documents, but what we are doing is we are moving towards consolidation of a lot of these products so that it improves uptake by countries, because we did a policy review in the high TB burden countries where we noted that while all these guidelines exist, there is poor uptake, and then the interventions are not reflected in the national strategic plans. There is limited harmonization across the different strategic plans for different disease programs in the countries. And there wasn't any active monitoring of these indicators in most of the countries. So to try and address that, we have developed the WHO framework for collaborative action on TB and comorbidities, which essentially which provides an approach, a generic approach for addressing TB and comorbidities from a programmatic perspective. So that includes how we do an assessment, how do we build this into strategic plans, how do we monitor them, and how do we collaboratively mobilize resources to address these comorbidities. So this framework is available online. And then in addition to the framework, we are also in the process of updating the respective guidance. So for TB HIV, we do have guidelines, and we are consolidating them in one place into the consolidated guidelines on TB and comorbidities, again, to present a one-stop kind of document that will have all the information on TB and comorbidities in one place. This is it's a stepwise process, so we will be developing for different products at different times, but ultimately we will have the consolidated guidelines on TB and comorbidities, which cover the key health-related risk factors that I've alluded to earlier. And this will be presented as a module on the WHO TB knowledge sharing platform. So this module 6 is covering TB and comorbidities. If I may shift now from the health-related risk factors to the socioeconomic determinants of TB. And again, I think just to reiterate, I've shared this chart before, that TB is strongly influenced by social and economic developments, as we can see on this chart, which shows the GDP per capita. And even historically, the countries where TB incidence mortality has declined, it has been mainly due to expanding UHC and rapid socioeconomic developments, in addition to effective treatments. And within selected populations, studies have shown that some individuals, there is a demonstrable association between social deprivation and risks for TB. And I'll give a few examples of this. And now we unfortunately have significant geopolitical conflicts and also the impact of climate change, which will have implications on economies, but also on food security, which has which will likely negatively impact on the TB epidemic. So this is just a visual chart which picks on a few indicators from the SDG monitoring framework. And it's basically to visualize the first chart, top right-hand corner. This is the incidence of TB. So the darker the shade, the higher the incidence of TB. And then top right, that's income inequality. Again, the darker the colors, the higher the inequality. Bottom left, access to social protection, similarly. So the main idea behind showing this slide is to just have an idea of the overlap between the incidence of TB in many instances and the distribution of these other SDG indicators that mainly relate to income inequality and social deprivation. So again, it comes back to the specter of ending TB. Ending TB will only be possible if we can address the factors behind the TB in addition to diagnosis and treatment. So this is just another example of some of the populations affected by TB. So some of the socioeconomic determinants. Again, in this particular study, this review was done to inform the guidelines on the management of latent TB infection in 2015. And you can see the relative risk of TB compared to the general population, was significantly, higher in inmates, up to 20 times, health workers, and even the homeless. Although this was not as strong, there were very wide confidence intervals. The association between TB and housing affordability as well was highlighted, I think, more recently, in a study by Lee et al. In a systematic review. So again, coming back, in most countries, and as we go towards TB, we go beyond ending TB and start to go towards TB elimination, it will become even increasingly more important to address TB in these specific populations. So in many countries, the high income countries, TB is already concentrated in specific populations. It might be immigrants, it might be the homeless, it might be prisons. So it becomes even more imperative to focus on addressing not just the disease, but also the determinants by focusing on those settings where transmission is taking place. And this slide just helps, to highlight some of the, that the impact of these determinants is not always that simple, So in this particular example, diabetes was found to be more frequent in indigenous populations in high-income countries than in low-income countries. Whereas the prevalence of alcohol was generally similar, in both groups. Smoking prevalence and smokeless tobacco consumption were usually higher in the indigenous groups than in non-indigenous groups. While food insecurity was very prevalent in most indigenous communities evaluated. However, substance use disorders were more frequent in indigenous communities in high-income countries compared with low-income countries, with wide variation across communities. Okay, so what, in a nutshell, what this tells us is that a lot of this action on determinants will require a lot of contextualization, because the interplay of the various determinants differs from one community to another. So it may not be as transferable that if what has been done in community A in addressing determinants will be the same in community B, even if it's addressing the same determinants, because of this intricate interplay of the various determinants in different communities. The relationship between TB and poverty is a two-way relationship. And in the Global Tuberculosis Report, we do report on the findings of TB patient cost surveys, where we report on the proportion of households facing catastrophic costs due to TB. And 27 surveys had been conducted since 2015. And according to those surveys, 48% of people with TB in their households face TB-related catastrophic costs. And this this ranged from around 13% in El Salvador to 92% in the Solomon Islands. And the proportion incurring catastrophic total costs was much higher, up to 82% for people with drug-resistant TB. So in essence, people with TB are likely to be further impoverished as a result of their TB, in addition to people with poverty being at increased risk of TB and of poor outcomes while on TB treatment. So again, my points today, I think many of you will be familiar with them. This is nothing new. I think even in the 80s, Rudolf Virchow had already highlighted TB is a social disease. And one of the most powerful, this is by Robert Koch, one of the most powerful weapons we can use against TB is social welfare centers. Again, this was recognized much, much earlier, even by the guy who discovered the bacteria that causes TB. And those who profess, this is Robert Tressel, those who profess to be desirous of preventing and curing consumption, which is TB, must be either hypocrites or fools, for they ridicule the suggestion that it is first to cure and prevent poverty. Again, this is 1912, more than 100 years ago, that it has been realized that, ending TB will require ending poverty, or at least addressing poverty. So we do have social protection as an intervention. And one of the things that we are doing as WHO is to further put focus on addressing social protection for people with TB. And I'll quickly run through a few slides on social protection. I think a lot of this, we have it already in, I think you will have these slides, if I'm not mistaken. But basically, these slides, they highlight the impact or modeled impact of social protection on the TB epidemic, as well as the potential that social protection can have in reducing TB incidence. So you'll have that access with that. But in terms of implementation in countries, especially focusing on people with TB, we have limited data on uptake of social protection. Only 16 of the 30 countries having national policies on social protection, and mainly free medical access, and maybe at least one other social protection intervention. But in terms of moving to address the social protection, the socioeconomic determinants of TB at a global level, and now looking at it from what WHO is doing, we essentially, and I liked this article which came out a few days ago by Ahmad et al., which basically highlights or acknowledges that the UN high-level meeting has moved to have specific targets on social protection, but it's now up to us to see how we operationalize that. And I think they conclude by highlighting the need for multi-sectoral action to address social protection. And just again, coming back to the UN high-level meeting, there are specific clauses that emphasize social protection, addressing determinants, as well as health-related risk factors of TB. And I'm probably speaking to the converted, hopefully, that social protection does work. It doubles treatment success rate. You can see on the study by Hudson et al. On the left. We got this slide also from Evans. Again, it reduces incidence of TB. It cut catastrophic costs. So these are just examples of the impact of social protection for people with TB. And in terms of what we are then doing to try and strengthen this, as highlighted by the various studies, that implementing social protection, it's not in the mandate of most TB programs to do that. But what we are now what we are doing is that we have this WHO multi-sector accountability framework, which provides a framework for engaging other sectors as part of the TB response. And this is linked to the WHO guidance for national strategic planning for TB, which pushes for holistic people-centered planning that addresses not just the disease, but also the determinants through linkages and collaboration with various sectors. And we will soon be launching the WHO ILO guidance on social protection for people affected by tuberculosis. So this will be launched in the coming few months, essentially to again provide a bit more concrete guidance to countries on the social protection interventions for people affected by TB. And this is partly towards the attainment of this new UN HLM target to ensure that 100% of people with TB have access to a social and to health and social benefit package, so they do not have to endure financial hardship because of their illness. So I think in summary, that brings me to the end of my talk. Again, it's addressing determinants of TB, health-related risk factors, socioeconomic determinants, and we're trying from WHO perspective to ensure that countries have the tools, have the guidance, and have the leadership and advocacy that is required to push the efforts to address this as a significant contribution to ending TB. I would like to acknowledge and thank you, Rajita and Daphne, for inviting me to be part of this talk. And also to acknowledge my colleagues from the People-Centered Services, Communities and Determinants Unit, specifically those colleagues listed there who helped me to also put together this presentation. Thank you so much. I hope that there is time for discussion. Back to you, Rajita.
Thank you so much, Dr. Mavhunga, for really a very interesting overview of sort of all the factors that come into play beyond the bacteria, which is really what, World TB Day sort of commemorated, was the discovery of Mycobacterium tuberculosis. But it's so interesting to see so many of the other factors that do come into play. For those of you in the audience, if you have questions, please feel free to put them in the chat or raise your hand and you can verbally ask your question. I wanted to begin by talking a little bit about asking you about sort of the realities on the ground at the Ministry of Health level. So you talked about how WHO is putting together guidance on strategic planning to sort of integrate programs, but what are really some of the challenges on the ground? I know at the TB and HIV level, they've done a really good job. TB and diabetes bidirectional screening is being done in many places, but what about some of the other challenges in actually making some of these to get these programs out of silos and working together? What are some of the things that might work well?
Okay, no, thanks a lot. Yeah, so I think you have touched on one of the biggest issues when it comes to these programs. Firstly, in most countries, the programs are not at similar levels of maturity. So you might have a mature, established TB program, but when it comes to other conditions, for example, you want to address smoking, you might not have a well-established, a well-developed partner program to collaborate with for some of those aspects. Similarly, nutrition, you might have sort of established nutritional programs, maybe for children only, but you may not have something that addresses the needs of other populations. So I think that's the first challenge, where having a counterpart program to collaborate with. And then secondly, we do have the benefit of resources. I mean, we know the global TB response is underfunded, but at least there is some targeted financing that is supporting the global TB response. So the issue of financing, dedicated financing for some of these programs also, it becomes a challenge in the field. And then linked to the programs, to having established programs, we also have, the advantage from the TB side. I think we are one of the programs with a lot of data, so we can sort of target our response based on the data that we have. But for some of these, comorbidities, we might not have as good, a set of data as we have for TB. So availability of data and even the systems to be able to obtain that, those data is also a challenge. And then maybe lastly, in terms of my, the countries that, I have interacted with, it's, I think many of the programs, they are like the TB programs, they are designed to take care of TB, not the person. They're designed to take care of TB. So we diagnose your TB, we monitor you, your TB is finished, we are done with you. So you might have other conditions, other needs, which beyond the TB, which is usually the case for most of the people who come with TB. So most of the programs they don't prioritize addressing the needs beyond the TB. So for us, if you're cured, we are happy. You might still be on a stretcher, but your TB is cured, so we report you as treatment success. So I think going beyond treating the disease to treating the person, I think it's a shift that many programs would need to do. And I think from our program, our unit specifically is we're trying to push more towards the needs of the person in addition to treating the disease. So that's where we're trying to sort of push that paradigm shift. What that does by default is that it forces the TB program to collaborate with the diabetes, with undernutrition, with mental health, with disability, because you're now looking beyond just the bacteria. So those are a few, but I'm sure colleagues who are online might have also other challenges that they might have experienced that they might want to share.
Yeah, anyone on the line, if you have other things you'd like to share, please feel free. I wanted to also ask you, you mentioned about certain special groups of people, such as minors, persons in corrections, correctional facilities, indigenous persons. What are some of the strategies to do outreach to those individuals? The traditional health worker in a facility, it would be difficult for them, right, to go into those areas, or individuals in sort of rural areas. What are some strategies that are recommended to reach those populations?
Okay, no, thank you. I think what you're highlighting is probably one of the most difficult challenges with accessing some of these populations. We, at the moment, in our department, we are developing a policy brief on addressing. We're using the term at-risk populations. I think we are moving away from vulnerable populations. So we are developing a policy brief on this, and the idea is basically to provide some kind of a framework. I think what we've learned so far from the discussions is that there is no one size fits all when it comes to addressing these populations. So there's the need for sort of customized approaches as much as possible to sort of population specific. So, for example, in some settings, for prisoners, they've used sort of the peer system whereby some of the inmates are used as community health workers to support education on TB or case detection on TB, etc. For mine workers, for example, in Southern Africa, it's almost like a public-private partnership model where, there is work involving the mining sector, governments, including TB programs, but also the mine workers unions involved in this. So it really requires a cross collaboration across the different stakeholders in trying to identify the appropriate interventions and ways to access. So through that, they established the so-called occupational health service centers, where people, ex-miners, could be, are screened for TB, specifically, focusing on those who have been working in mines or in peri-mining communities. So in a nutshell, I think for many of the communities, it requires engagement and understanding the needs of that specific community. I did have the experience of working with the nomadic San community in Namibia, also called, they were previously called the Bushmen. And in that community, we had to establish, even before ambulatory treatment for drug-resistant TB was allowed, we had to establish that by, because there was no other way to ensure that people in that community, get treatment. So again, highlighting again that, I think for many of the populations, it requires engaging the population, engaging the stakeholders, and coming up with a bespoke approach to address TB in that community.
Dr. Elner, you had your hand raised. Do you have a question or a comment?
Yes, nice to meet you, Dr. Mavhunga, and thank you for your presentation, perfectly in line with the World TB Day. So report does observational research and translational research in the interest of developing new tools. And I wondered what you thought would be most valuable in terms of new tools, and also how we could foster better communication between researchers and WHO and control programs. Thank you.
Okay, no, thank you so much. So in terms of fostering closer collaboration between WHO and, so WHO, we have, at least from the TB side, we have an annual research to policy forum where we, from WHO, we highlight some of the areas that we are working on and what the research gaps are in those areas or other areas. That's number one. And then number two, when we have our guidelines development group meetings, one of the, the outcomes from the GDGs is also a list of research priorities, areas around that topic where we do not have adequate data. And then the third option is when we are, usually it's at the union conference, we also have sort of targeted sessions looking at research that is ongoing, as well as, for us to also be aware of any new research that might come up, which may require us to review and update our guidelines and guidance and tools. So there is a lot of work happening at different levels in terms of diagnosis, in terms of treatment, in terms of prevention, but also in terms of vaccine development. Maybe the area that, coming to determinants specifically, and this comes back to social protection. We are now moving to try and expand social protection for people affected by TB. But if according to that study that, that Evan et al. Sort of showed, no, sorry, Tom Winfield et al. Showed, really the operational aspect, how do we operationalize social protection for people affected by TB? Acknowledging that TB programs are not designed to provide that. How do we then move from having a target to actually operationalize these commitments? And then at the different, along the diagnosis to cure pathway, I think there are various sort of tools, methods that are being researched to try and optimize either the existing tools or new tools. But I can link you up with some of our ongoing sort of work on the various areas, if there's a specific area that you would like to hear a bit more about, especially on new tools.
Okay. Thank you.
Are there any other questions? There was another, someone did make a comment in response to your discussion about the challenges on the ground. So they also, Erlina added that the challenges to country implementation include infrastructure, diagnostic tools, drug availability, and local government commitment, and mentioned how the COVID-19 pandemic has a lot of great lessons to be learned. So that's another additional comment. So I want to thank you again so much for doing this talk for us. It really is just amazing, sort of where we've come and where we still have to go in terms of TB elimination. But hopefully, given some of the work that's being done at WHO to sort of again consolidate and really respond to things beyond the medical factors, I think will hopefully send us in a more hopeful direction. So we really, really appreciate you taking the time out of a very busy schedule to join us today. And we look forward to hopefully some more for future collaborations with you and your group. Thank you again.
Thank you so much for having me.
Okay. Goodbye, everybody.